Hello, welcome back. Today we're going to be starting a new series on diabetic retinopathy. Diabetic retinopathy is a big issue in the United States and in other countries. We're just going to be doing an introduction. We're going to be covering certain specific aspects, but for more details about some of these things, I'll be referencing other videos that I'm posting on this subject that deal with just specific things that you'll see momentarily. Just a reminder, who am I? My name is Zackery Oakey. I'm a retina specialist here in Irvine, California. That's me in the building I work in and my website. Every video we do starts with understanding the anatomy of the eye. Diabetic retinopathy refers to a problem of the retina, and the retina is back here on the inside of the eye. The retina has one job, and that is to feel the light. The light is felt because it's put into focus by the cornea, the lens, maybe a pair of glasses that are in front of the eye or contact lenses. Well, the retina, after it feels the light, it talks to the optic nerve, and the optic nerve goes to the brain and tells the brain what the retina is feeling. Now, to understand diabetic retinopathy, we have to understand the anatomy of the eye a little bit. In the back of the eye in this cartoon, there are several things here. There are blood vessels, what we call arteries and veins. Diabetes affects the body, not just the retina, but it affects the body through changes in the blood vessels throughout the body. There are two specific things that happen when people have diabetes, particularly if people have had diabetes for a long time, or if the diabetes is not well controlled, if the blood sugar is always high, or the other things that happen around diabetes, high blood pressure and high cholesterol, continue to exist. Blood vessels begin to close, and they also begin to leak. And this is why people with diabetes develop things like heart attacks, kidney failure, sores on the skin, neuropathy, and so on. These all come from poor blood flow. Now, this is just a cartoon of the eye. In a real human eye, this is what the arteries and veins look like. Again, when we find diabetic retinopathy, that is diabetes affecting the retina, we find that there is inadequate blood flow or many other signs of that. This is what a retina looks like when there's diabetic retinopathy. There are all these little blot hemorrhaging things. See all these things? They're everywhere. And also, there are these kind of white marks and stuff. So this is diabetic retinopathy. This person actually probably sees 20/20. So in order to understand diabetes, in every talk we give about diabetes, first we need to understand how prevalent it is. In order to understand prevalence, we do studies called epidemiologic studies. This is where a research institution invites people with a condition to come in to a clinic or to a university, and images are taken, people are interviewed, and we start to understand how common something is. There are many studies that have been conducted to ask this question. Here are a list of several. These are a bunch of studies that have been conducted over the course of decades. Notice most of these are done in the 80s, 90s, and early 2000s. This was, shall we say, the heyday of diabetic retinopathy research with respect to understanding how common it is. There are a bunch of things that are reported in these studies. For example, how many men and women get it, what are the age ranges, what kinds of ethnic groups, how severe is it. Let's just hone in on one specific subject, which is how common is it. In one study that was conducted in Wisconsin, about half of participants who had diabetes had diabetic retinopathy, but in these other studies, the range went from approximately as low as 27%, for example, all the way to 50%. There are estimated 30 or 40 million people in the United States at least with diabetes. So if we go by these numbers, perhaps we would suggest that about 10 million people in the United States would have diabetic retinopathy. The number is probably actually a lot higher than that because we can't invite everyone to the clinic. We can only get a slice of the population when we study this, but let's just call it 40 or so percent of people with diabetes will develop diabetic retinopathy based on these studies. And of them, a certain percentage are being threatened by vision loss. That number could range anywhere from 4 to 10% of those with diabetic retinopathy. How many could develop some form of vision loss from diabetic retinopathy? If you do a basic calculation, that's a lot of people. That's why we say this is the number one reason why people go permanently blind in the working age population in the United States. Now, the reason why people lose vision, again, remember back to when we were first talking about this, diabetes affects the way blood flows. And we do a certain study in our clinics to understand how blood flows specifically in the retina, in the back of the eye. And this is one such study. This is called angiography. This is where someone receives an injection inside of the vein with contrast. It's a very special contrast only used for the eye. And when people do not have any diabetes, this is what the retina looks like. Perfect blood flow. Every blood vessel inside of this eye has blood flowing in it. The contrast is flowing in it, and so on. This is what it looks like when someone has pretty severe diabetic retinopathy. Notice the difference. Notice how poor the blood flow is. But there are also other things happening here. For example, if we look at the eye with diabetes, there are these white dots everywhere. There are thousands of these things. These white dots are what we call microaneurysms. When we say the word aneurysm, usually people get really scared, and for good reason. If someone develops an aneurysm but inside of the brain, that could potentially be debilitating or lethal. But throughout the body in diabetes, people can develop tiny, small little aneurysms in the tiny blood vessels throughout the body, including the retina. Now, these tiny aneurysms really don't affect vision directly, but what an aneurysm is a blood vessel like an artery. If it's carrying blood from the heart to an organ, there can be one little section where it's kind of weak, and that's one section where there may be bleeding, but also that one section can also leak a little bit. And in the retina, all of these thousands of little aneurysms, they can leak over the course of time. And if we continue to take photographs of someone who has contrast flowing throughout the vein, all the veins inside of the eye that is, we can start to see leaking throughout the retina. And this is what it looks like when the contrast is leaking out of all these white dots. The contrast is kind of cloudy. It's leaking out of all the blood vessels. And this is what the retina looks like. Now, if we were to examine this person's eye, first of all, we would find that the vision is pretty fuzzy, but also that the retina is swollen from these points, from these aneurysms leaking inside of the eye. Now, there's one other way to assess whether or not someone has leaky blood vessels and a swollen retina, and that's by scanning the retina. That's using this special technology. This is what the retina normally looks like when we scan it. However, if someone has swelling in the retina due to diabetes, this is what it looks like in this photograph down here. So if we compare the first photograph, the retina normally has this like nice little dip in it, right smack dab in the middle. But in someone with diabetes, notice this person has diabetic retinopathy, plus all of these little yellow crusty things that happen when the retina is swollen. The retina is really thick and swollen. Someone has a hard time seeing clearly, even with perfect glasses. Remember, the retina feels the light. So even if the light is put into perfect focus, if the retina is swollen, then the vision is really fuzzy. Now, remember also I told you that diabetic retinopathy causes poor blood flow. This is what the retina looks like when there's poor blood flow. Just going back to a similar photo that we saw before. This section right here, this section, that section, and so on. Basically, the entire bottom half of this retina is not receiving enough blood. But the thing is, the retina is still not quite dead here, where the retina is not receiving enough blood. And so this part of the retina that's still alive is still demanding help. And all of the parts of the retina that are still getting enough blood, like for example over here, let's say they're willing to help. They want to help out. So this part of the retina, hearing the cries, shall we say, of these sections of the retina not getting enough blood, this section of the retina says, shall we say, I want to help out my pal down there. And so what it thinks is helpful is that it can form a blood vessel to connect those parts of the body that are still flowing in blood with those parts that are not receiving enough blood. It sounds like a good idea. It's almost like if a farmer has a crop and that crop is not receiving enough blood because, like, let's say there's a beaver dam or something, a farmer could tear down the beaver dam, which might be tough, but also the farmer could just build a second canal around any obstruction in the water flow to the crop. Well, it sounds like a great idea. The problem is, It's not a good idea, and allow me to explain why. This is what it looks like when new blood vessels grow, that is, as an effort to bring blood to parts of the retina that are not getting it. If we look at an eye with this stuff happening, this is what a blood vessel looks like normally, but notice over here there is an abnormal collection of blood vessels. This thing right here. It's almost like it's like a leaf of a tree kind of sitting on the surface of the retina. These blood vessels, they don't really do what they are intended to do. Like, for example, if there's poor blood flow down here, and the idea was to connect this part of the blood flow down there with a nice connecting tube to deliver blood to the retina, it's not really doing that. It's actually sitting here feeding itself. And this can also happen in other places. This is happening on the surface of the retina, but also it can happen on the optic nerve as well. This is, as it says here, this is not normal. These are new blood vessels that are sitting there on the retina forming, and they're not really helping anything. They're just sitting there feeding themselves. Now, this may not be a problem in itself, let's say, but there's one special thing to consider about these blood vessels, and that is that they're very fragile. These blood vessels, they act differently than the ones that we are born with inside of the body. Like if you look at your hand, you can bump your hand into stuff, and the blood vessels in your hand, the ones that you can see on the surface, they tend to be okay. Maybe they get a little bit bruised, but these things are very different. If someone with these things growing inside of their eye sneezes, laughs at a joke, bends down and ties shoes, lifts something heavy, these things will start to bleed inside of the eye. And the bleeding inside of the eye can be really severe. This is what it looks like when there's bleeding inside of the eye. So inside of this eye, there are new blood vessels forming here, for example, and right there, but there's also one underneath here that you can't see because that new blood vessel that was sitting there has ruptured, and now there's this big puddle of blood in here. This person is legally blind. Now we can fix this, and I'll walk you through how we fix it momentarily, but this is one way in which people with diabetic retinopathy lose vision. Now there's a third way. We've talked about swelling of the retina, we've talked about bleeding on the inside of the eye, but there's a third way that people can lose vision from diabetic retinopathy, and this is an example of that. In this person, there are all the hallmarks of diabetic retinopathy, like over here, there are these little hemorrhages here and there. And then there's also bleeding inside of the retina. And then here we see those abnormal blood vessels growing everywhere. There's poor blood flow all around here. And this is what we kind of saw in the last photograph, except there's one big exception. There's one big difference. You see this thing here? There's a band of scar tissue forming. So what happens when these blood vessels develop and the body recognizes they're not really delivering the blood to the intended target, and they're causing trouble, they're bleeding inside of the eye, the retina, shall we say, regrets its decision, and it tries to clean up the mess. But the way the body cleans up messes is not like taking a broom and sweeping something away and throwing it in the garbage. That doesn't happen inside of the body. The way the body cleans up the mess is by using the immune system. The immune system is a part of the body that fights infection, but also cleans up the mess. And whenever the immune system is invited to a place, it does a pretty decent job. Like if we get an infection in our skin or strep throat, it takes care of the bacterial infection, or it prevents us from getting infected in the case of like a cut in our skin. But in the case of the retina, when the immune system shows up to clean up the mess, shall we say, it leaves behind this band and all sorts of problems, what we call scar tissue. Now, again, just like the previous example, this wouldn't be a big deal if it just kind of sat there, but it doesn't just sit there. The scar tissue that forms on the surface of the retina, it has one important quality that's important to understand, and that is that the scar tissue pulls, it contracts. And if the scar tissue pulls hard enough, if it contracts hard enough, it can cause what's called a retinal detachment. A retinal detachment is a blinding condition. If the retina detaches, that means it falls off the back of the eye. And if the retina falls off the back of the eye, it doesn't work very well at all, and the eye goes blind. And that sucks. It's really bad. In fact, it's really bad, particularly if it involves the middle of the retina. Remember, the middle of the retina is here. That's where all conscious vision happens. And in this particular person, again, using our special scanning technology, we can actually see what's on the inside of there, even though there's a little bit of blood in the way. And let's remember, this is what the retina normally looks like on the middle of the retina. And this is what it looks like when someone's retina is detaching. See, the retina, it's almost like it's being pulled up in the very middle. There's this fluid collection underneath the retina because the retina is being pulled off the back of the eye. Now, we can fix this, and this is what the eye looks like after it's been fixed. Notice all that scar tissue's gone, all the blood is gone. There's still some signs of diabetic retinopathy, but there are all these little marks here, all these yellow kind of black looking marks. I'll walk you through what that is momentarily. The thing to understand about a retinal detachment in general, no matter what the cause is, specifically including diabetic retinopathy, is that the retina is never normal after this. People always have limited vision even after we do this nice beautiful surgery and resolve the retinal detachment. And one way to understand that is by scanning the middle of the retina again after things have been fixed. And in this particular example, this is what the retina looks like after things have been fixed. Now if we compare average, that is, average is here, and this is our patient who's had a retinal detachment, if you just compare the differences, there are many things to note. Like there's a bump here, things are missing here. Like for example, if you come over here, you see that there are all these white layers on the inside of the retina. In this case, it's kind of damaged and missing there. It's pretty good over here, but it's damaged and missing there. Same thing over here. It's kind of irregular in contour. This is a great result, but the vision is always limited for this person. Now, there are a bunch of ways that we take care of diabetic retinopathy. That is, there are many things that people like I do. There are basically three categories of things. We inject medication into the eye, we perform laser procedures, and we also do surgery. Now, the time in which we do injection inside of the eye is when there's swelling in the retina or there's active bleeding on the inside of the eye. An injection stops the bleeding. The blood that's in the eye, we wait for it to go away. By the way, I have a whole separate video just on bleeding of the eye. Also another video just on swelling of the retina, all due to diabetic retinopathy. So if you're interested in the tiny little details of those subjects, I'd encourage you to see those videos. But needless to say, injection is really effective to stop bleeding and to treat swelling of the retina, but that's really its only role. Laser is meant to prevent bleeding. In the past, we used to use laser for swelling of the retina, but we found that injections actually do better than laser when there's swelling inside of the retina. So basically, laser is a preventative technique, and that's what this is. All these yellow, kind of black-looking dots, those are laser marks that are throughout the retina. Given the fact that this person received this much laser, they are very, very, very unlikely to bleed ever again. And they're also very, very unlikely to ever develop a retinal detachment because of the laser. And then the third and final thing that we do is surgery. You saw an example of that. That person who had a retinal detachment, we very carefully disassemble all the scar tissue there so that the retina can relax and the vision can get better. Again, not perfect, but it can get better. And we also do surgery in the eye if there's bleeding inside of the eye and for some reason we can't stop it with injections or it doesn't clear out as much as we would like. Now, these are the things, like I said, that I do for someone who has diabetic retinopathy, but people who have diabetes, you, for example, if you have diabetes, there are many things that you should be doing both to prevent diabetic retinopathy and if you have diabetic retinopathy to make it better. There are basically three categories of things. Number one, be my best friend. The American Academy of Ophthalmology and many other national and international organizations recommend a dilated eye exam the moment diabetes is diagnosed. Now, there's some caveats to that, but just for simplicity's sake, keep it at every year. If things are going well, the diabetes is under good control, we still suggest an annual dilated eye exam. Now that recommendation can change depending on how the diabetes is going. If the diabetes is not well controlled, if the blood sugar is high, if the blood pressure and cholesterol are high, maybe we'll suggest examining the eye a little bit more frequently than that. Let's say every 6 or 9 or even maybe every 3 months. But generally speaking, it's an annual screening exam. The second thing to do is to be best pals with the doctor who's helping you with your diabetes. That could be an endocrinologist, a family doctor, an internal medicine doctor, whoever it is who's competent at managing diabetes, recommending modifications to the diet, medications, and so on. They need to be your best pal because they can help you prevent all this stuff. And number three, when you're with one of these doctors taking care of the diabetes, there are three main things to pay attention to. One of them is this lab called a hemoglobin A1C. I've met people who are blind from diabetes, who have kidney disease, who are on dialysis, who are missing a foot, who have had a heart attack, and they don't know what the A1C is. I think that's a shame because the A1C is a lab test that we do that helps us look at the future. The reason why I say that is because if the A1C is high and it remains high, then we know that the chance of blindness, kidney disease, foot infections, heart attacks, and so on is also really high. It's almost like a crystal ball, and it's expressed as a percentage. So for example, if someone doesn't have diabetes, their hemoglobin A1C would be like 4% or 5%. But the moment someone has an A1C that's 6.5% or more, they have diabetes, whether it's well controlled or poorly controlled. A hemoglobin A1C that's like 9, 10, 11, 12 or higher percent is at really high risk of going blind, having all the other things that we talked about, plus dying early. So I think that this lab test is really important. Like I said, like a crystal ball. If the hemoglobin A1C is 10%, that predicts all sorts of problems. It's basically looking at a crystal ball and seeing dialysis, infection, and blindness. So it's important to stay on top of it. Now, blood pressure and cholesterol also play a role. They're like the henchmen of diabetes with respect to diabetic retinopathy. If the blood sugar is high, but also the blood pressure and cholesterol are high, then the diabetic retinopathy is worse than, let's say, if the blood sugar alone is high, but the blood pressure and blood sugar are fine, and cholesterol are fine. So anyway, these are like the main things to be doing. Be my best pals, be good pals with a doctor who manages diabetes with you, and then stay on top of these specific things. We tend to succeed. So in summary, we've talked about diabetic retinopathy. I told you it is the number one reason why people are permanently legally blind, particularly among the working age population in the United States and many other countries. It's present in about 30, maybe 50% of those with diabetes. It threatens the vision of maybe 4 to 10% of people when randomly sampled in studies. It causes swelling of the retina, bleeding of the retina, and retinal detachment. We treat that with injection, laser, and surgery, and it's really important to stay on top of the hemoglobin A1C, blood sugar, blood pressure, and cholesterol to prevent all this stuff. Or if there is diabetic retinopathy, make it go away, make it better. So that's me. This is my clinic. Again, if you're ever in the neighborhood, feel free to stop on by. I appreciate your time.